can start your presentation at any time.
Everyone, and welcome. I am honored that I will be doing a webinar for you on staff roles and training for the Pressure Ulcer Prevention Program. This is an exciting topic that's important in the overall Pressure Ulcer Prevention Program. Before we started with the actual content, let me tell you a little bit about me. Currently, I am a board-certified wound endoscopy nurse. For over 25 years, have served as a clinical editor for the journal Advances in Skin and Wound Care. I'm also the Vice President of the World Council of Ventrostomal Therapists, or the WCET, a faculty member at Excelsior College School of Nursing in Albany, New York. I'm the author of over 100 peer-reviewed journal articles and 2 wound care books. I have been the president of the National Pressure Ulcer Advisory Panel, or the NPUAP, and a consultant to the Centers for Medicare and Medicare Services, or CMS, pushing for guidance to surveyors for FTEC 314 on pressure ulcers and skin conditions for long-term care, long-term acute care hospitals, or LTACs, inpatient rehabilitation facilities, assessment instrument, or IRF-PI. I've also been involved in several pressure ulcer to reduce the pressure ulcers, working on a systems level, and I weave in my experiences about those initiatives throughout the presentation. So today I want to talk to you about some of the key elements that are contained in the AHRQ Pressure Ulcer Prevention Program Toolkit. What about the roles and the duties of staff? How you organize within your institution, your plan, particularly at the unit level, because that's really key area, because that's where the patients are. So doing the development of the plan at that level is key to an effective intervention. Training the staff on the new practices that they're going to need, or revisions of practices, reducing pressure ulcers in your institution. Topics were previously introduced to you in your one-day training. We're going to revisit them in a little bit more depth. I have questions during the presentation, so I'm going to ask you to write them down, and at the end, you should follow up with your quality improvement specialist after the webinar to address them. Also, at the end of the presentation, there is a list of resources with the citations for some of the references that I'll be going to today during the seminar. So that said, let's get started with some more detail about how you can help to reduce pressure ulcers in your hospital. As you hear, there are some key elements to the program. Pressure ulcers are a skin phenomena. In your pressure ulcer reduction program, you need to make sure that there is a comprehensive skin assessment done by your staff. There was a separate webinar done by Dr. Karen Zukowski that covers this topic in great detail. So I would refer you to that and all of her suggestions and recommendations of how to do it and how to incorporate that from a systems point of view. We have standardized pressure ulcer risk factor assessment. Again, there is a whole detailed webinar on the very topic which I have previously done. You might want to take a look at that webinar because it goes into great detail about how to use standardized risk factor assessment tools, how to look at risk factors beyond those tools, and how to group them all together in a comprehensive review of risk assessment for the individual in your hospital. And that seminar also included care planning and implementation to address those areas of in great detail. From a systems point of view, look at this joint plan in your hospital. Who's going to be delivering the messages, to what group of people, how they be delivered, and how are you going to measure the effect of all these elements of a successful pressure ulcer reduction program. See some of the teams or components to successful pressure reduction programs. There are suggested teams that you might want to assist in your institution. And as you can see here, the roles and duties for each of them need to be clearly defined and made clear to all that are involved. And I'll talk about each of them, the implementation team, the wound care team, the unit team, and the skin and the unit champions throughout today's webinar. What we're doing is you are really helping to assess what the knowledge is in your institution, what your current care practices are, how do you want to change them, and then that change into action in your institution. Slide, you'll see some of the interdependence of these teams and their relationships. And diagram you will find in the AHRQ kit. Excuse me. You'll see that the implementation team is really looking at the big picture in terms of the fact that they will be designing and implementing and many times have overall responsibility for the pressure ulcer change project. They usually are at the highest administrative level, but a good representation of clinical and administrative people and across the interdisciplinary team of professionals will enhance your implementation team. Your team are experts in skin and wound care at your institution. They serve as their resources for staff as well as for patients and families. And it's down to the unit-based team. These are the people who are providing the care to the patient and their families day in and day out. So actually doing the pressure ulcer risk assessment and the care planning. Presentation team and what they do are looking at the big picture. What are the procedures and policies that we want to have in place in our institution? In some of the hospitals that I have done consulting, I've found that the implementation team, if a highly engaged administrator on that team, they have much more success. So it sends a very strong signal to each and every person on the unit that pressure ulcer prevention, pressure care is really important in our institution. The fact that a high-level administrator is on the team. Think about that when you're designing who is going to be on your particular team in your hospital. The people who keep up to date on all the details, all the clinical guidelines, and hopefully by now you have had a chance to look at the newly released, the end of 2014, National Pressure Ulcer Advisory Panel, EPUAP, or the European Pressure Ulcer Advisory Panel, and the PPPI, which is the Pan-Pacific Panel for Pressure Injury, pressure guidelines. These are a revision of the guidelines that were put out in 2009 by the PUAP in collaboration with the European Pressure Ulcer Advisory Panel. So the international guideline really serves as a resource for content experts to look at what the evidence is saying in terms of what needs to happen in your hospital pressure ulcer prevention. If you've already read it, you can go to the NPUAP website, which is www.npuap.org, and you can download for free the quick version of this guideline for your use. Obviously, the wound care team, because of their clinical and their knowledge, expertise, are a source about what is the most current happenings in terms of skin and wound care practices. And wisely, because they are there to help you. They are a fabulous resource. The team, I mentioned earlier, they're the ones who are actually implementing the direct patient care. They're the ones touching the skin, bathing the skin, transferring the patient, doing the pressure ulcer risk assessment, doing the skin assessment. And I want to emphasize a very important fact that has been a recurring theme through several of these webinars. That pressure ulcer risk assessment includes doing a skin assessment as well as standardized tools. Them go hand in hand, no pun intended, since you'd be using your hands to be looking at the skin. Please make sure that everyone in your unit understands the role that skin assessment plays with pressure ulcer risk assessments. They will actually be implementing the interdisciplinary plan of care to prevent pressure ulcers. Talk about that in more detail in another webinar. But remember that you need to address any factors that the patient may present with. So not just about the overall score, it also is any risk factors. For example, if your patient is incontinent, you need to address the incontinence regardless of what a total Braden score may be. If the patient has nutritional deficits, you need to address that. If the patient has comorbidities, which we know impact on circulation, they should take extra care to prevent skin breakdown as a pressure ulcer. The patient profile, for example. So all factors need to be looked at in the plan of care, and then everybody from an interdisciplinary point of view needs to understand and know what we're doing for the patient. And of course, all heard the mantra that if you didn't write it down, you didn't document it, you didn't do it. So you need to make sure that all the wonderful care that you have done for your patients that you actually did is documented in the medical record. The team member needs to know what they are doing, and throughout the AHRQ toolkit, there are some reminders that will help you in terms of down what each person can do. If people know what these roles, what these duties are new, and help them to navigate the newness of something. Most of us are excited about new things, but there's also a little sense of, can I really do this? Do I really want to do this? Can be another thing. So certainly attitude is going to come into play for staff. So make sure that you help them with this change to what they'll be doing now for the patient. Make sure that everything that people are doing for pressure ulcer prevention is in line with the Practice Act for your state. Now, sometimes there's resistance and there are barriers for people to fulfilling their role, and that is best addressed by looking and assessing people's attitudes and helping people with change to their new role. Having them feel confident, having them feel competent, having them feel comfortable is important in terms of overcoming barriers. So ask them. And we'll talk a little bit more about that later on. And make sure that people have adequate preparation that have been oriented, and they know what they're supposed to do, and that they understand how you're going to be monitoring the work. And don't forget temporary staff. You know, in some institutions, besides your regular staff, you have temporary staff that may come be doing the actual care on the unit. So make sure you know how they know what your practices are and what your pressure ulcer prevention initiative looks like so they can participate. You are responsible for all staff in your institution that are providing care. So the concept of unit champions is described in the literature. It's one of the strategies that works very well. And how many you need is really going to depend on the size of your hospital and what your staffing capability is. Now, obviously, it's optimal if on every shift on the unit, there was somebody who was adequately trained to be this resource, which is what the unit champion is. If you can't have on every shift, perhaps you can have at least on one shift. And don't forget weekends. There are less people around, so having somebody available also on a weekend is optimal. And if it can't be on your particular shift, or maybe you could share between two shifts if somebody needs to call somebody from another unit. It's better to have an actual care provider or a bedside RN who is a unit champion. One of the ways to do this is to ask for volunteers. When people volunteer, they're more enthusiastic, they're more interested in pressure ulcer prevention, and more likely to be a cheerleader for your initiative. So that's a strategy that you might want to do. Your nursing assistants or nursing attendants and your licensed practical or licensed vocational nurses, you want them involved too, particularly since many times they may be the ones that are seeing the skin more than the RN. And you want a coordinated team of all levels of nursing personnel, as well as your interdisciplinary care. And, if possible, try to have your unit champions that probably are going to be on for a while to avoid the reorientation of people. So commitment is an important thing. Now, one of the things that some hospitals have done is that unit champions actually get a bonus, and the bonus can be financial, or the bonus can be an extra conference day, or something very tangible, so that being a unit champion a built-in reward other than the title. Some people, title's enough, or a button designating them as the pressure ulcer unit champion. In many institutions, when money and an actual day off or conference attending paid for really helps to make people more motivated to be a unit champion. Make sure people on your unit know, well, if my unit champion is off or not working on my shift, what do I do? Where do I get resources? Is there another unit I can call? Who do I contact when I need that kind of information? Who should be your unit champions? You can see here that there's quite a list, and certainly someone who's involved in professional practice, somebody who can communicate well with all levels of staff. And I think that's very important because people will listen to the message from the messenger when somebody communicates in an appropriate manner, has the right attitude. You need to know that the unit champion knows how to use their links and networking to all of staff members. It's essential that they have the respect of their peers and they're not seen as somebody who's hoarding information, but somebody that's helping with information. So they have the respect and admiration their peers. People are more likely to go to the unit champion and ask questions without fear that the unit is going to think that they're dumb, or you should have known that, or how come you don't know that? So that's really important, how the members on the unit see the unit champion and how respected they are. Have a positive image of a unit and really set the tone for the level of care that everybody wants on the unit. Unit has to have good problem-solving skills because sometimes it requires really drilling down on a situation and seeing what's going on and being open to all kinds of information. And if pressure also occurs, really looking at the situation and helping everyone to understand how it happened and how we can prevent this in the future. The ability to work with all the key stakeholders. So you need a champion who will be able to communicate with people at the administrative level, people who are certified, for instance, in skin and wound care and will not feel intimidated. And I think that it's key that they are passionate and that they have knowledge about pressure ulcers. Passion is the most important thing. You can always help them get the knowledge, but without passion, they really are not going to do a good job of being in the unit. It can be perceived as a burden rather than somebody who can really help facilitate care on the unit. USU champions really serve as a liaison amongst the teams that I've already talked about. They're going to help resolve the issues related to pressure ulcers. For example, if when the pressure ulcer incidence comes back for your particular unit and it's not going down, it's not being reduced, rather than coming back and blaming the staff, they may be able to help the team understand that we have a staff that's brand new to our unit, and so that we're in the process of orienting them. There's been a lot of change and a lot of shift going on staff, so maybe when that settles down, we'll be able to see a reduction in pressure ulcer incidence on a unit. They're going to implement the pressure ulcer prevention strategies. Remember, they're the cheerleaders. They will help people know what the intervention plan should be, and they're the ones that will help everybody when they are in there doing these interventions over and over and over again, because one of the problems with pressure ulcer prevention is very routinized. You've got to keep doing things over and over again, which for some staff is boring, like doing risk assessments every shift, for example. How many of them are going to need to do it? So keeping their enthusiasm up is important. That's the cheerleader role. And they can safely go to the unit champion when they have questions without fear of retaliation. Also very familiar with all the program goals, the care processes, and need to know the outcome data. In a survey that I just published with Sharon Baranowski in Advances in Skin and Wound Care in August 2014, we found it very interesting that in a survey of nurses, over a third of the nurses knew what their unit's per incident rate was. Actually, it was 38% knew what it was. So I think that it's really important that everybody on the unit should know their pressure ulcer incident number. Sometimes assume that they do, but they need to know what their number is, and they need to know how it's trending, if it's going up, if it's staying flat, if it's going down, and help them to interpret the number, because there might be reasons why the pressure ulcer incidence rate is not changing. Some other things are that they will help transfer knowledge about pressure ulcer injury prevention, and that's where the new guidelines, there are 475 recommendations in the new NPUAP, EPUAP, PPPIA pressure clinical guideline. So everybody's not going to know all of them, but the unit champion can help others on their unit know about the latest practice that will help prevent pressure ulcers on their unit. They'll be involved in tracking the numbers on their pressure ulcers and make sure that everybody knows what that number is as the unit expert, and help bring information to the managers and supervisors and peers and patients on what pressure ulcer prevention practices are working on the unit, which ones are not, any problems that are being encountered. What about the equipment? Is it available? Are you having any problems using it? Do you need to do any clinical trials of new equipment, for example? What else do you need? So the resources that you need on your unit are communicated to those that have administrative ability to make that happen. In relation safety clinical processes, what happens when a patient goes off to, let's say, have a test? How does the staff in, let's say, a procedure or x-ray know that this is somebody who's at pressure ulcer risk, and you want to pay a lot of attention to the skin as you move them from the stretcher onto the examination table, because we're really worried about the ability of their skin. Of course, involved in doing the ongoing pressure ulcer surveillance and collecting what the numbers are and helping to look at the data outcomes from those audits to help interpret them and make sure that this data goes up to the implementation team as well as down to all members on their unit. And, training their peers, they will be doing in-services, and find short little in-services usually are very good for on the unit training. Staff has very little time. Quick, 5 to 15 minutes on a very focused aspect of pressure ulcer prevention can be really helpful for the unit champions to do. They can help orient the new employees when they actually get to the unit. They probably had something didactic in the new employee orientation, but how do we implement this here? What is the reality on our unit? How do we get the support services? Where are the skincare products kept on our unit? How do we use them? Where do we keep our pressure risk log for patients on our unit? So this kind of information will be very important for the unit champion to give to new employees. Training and retraining or education is ongoing. It's constant. And certainly anytime any new equipment is in, they can be involved in the training, and also spot checks to make sure that people haven't forgotten and there's no slippage in terms of how to use equipment. Because sometimes when you use something for a long time, you start taking little shortcuts. So it's good to make sure everybody's doing everything the way they should be. And certainly the patient and their family are a very important part of the pressure ulcer prevention team. So what tools do they have? Do they have pamphlets, or do they understand how to do the education, what elements are included? And there is a patient booklet that's available in the AHR toolkit that staff can use, and it's tool 3G in the resources at the back of the toolkit. And it actually was created from the New Jersey Hospital Association initiative, which I served as the chairperson of. Patient education booklet is available in English and Spanish on the New Jersey website. You need to organize how communication and reporting is going to occur on your particular unit. So may have that will identify who on your institution, on your unit, is at risk for developing a pressure ulcer. An example of one of those is the resource section of the back of the AHR toolkit. I think one of the most important things that I've learned is staff is very, very busy. So some ideas of how to integrate the prevention processes into their everyday work is really important. So don't see this as extra work, but that this is necessary work. But how do I get it done with all the other things that I have to do to take care of my patients? People in the hospital are very sick, so it's important that take care of their skin and pressure ulcers as well as all the other needs that they come with. So need for ongoing communication within the unit. I need to use language that staff is going to understand. So not talking above or below the level of the person. And this is really important also when you're talking with your nursing assistants. A vital part of the team, and explaining to them what risk assessment is, why you're doing a Braden scale, why you're asking them to cleanse the patient after every episode of incontinence, because it makes the skin more vulnerable to break down from pressure. The skin can't tolerate pressure as much when it's wet or very dry, and that putting that skincare protection product on the skin, whether it be a cream, a lotion, or one of the liquid sealant products, is a very important intervention. And I never cease to be amazed how important it is to really help empower nursing attendants and how the actions are really important for ulcer prevention. They may not see it that way, but once you put in that kind of language that they understand they should be doing and how it contributes to the overall effort, you can really see it sometimes in people's willingness to do the plan of care that they need to do. And obviously people need to understand that what they can do and also what can't be done. Science give updates at regular meetings of the implementation team, how we're doing, any barriers we see. Unit managers are going to give updates about the data from their staff and how processes are flowing and what the rates are. Staff document the pressure ulcer risk or presence on their flow sheets, and everybody needs to know where that flow sheet is. Some people who have electronic medical systems, that can be electronically triggered as a data element, so it doesn't have to be a handwritten flow. But for those of you who don't have electronic, there is a sample of that in the section of the AHR toolkit. Examines the patients at risk. Interdisciplinary skin rounds are very helpful. Everybody sees from a different point of view, so the more eyes that look at the patient and look at the skin, having an integrated team, and I think that's where we're going in the future of healthcare, and skin rounds is a wonderful way of having an interdisciplinary team do it. It's not blaming people, but it's what do you about this person's skin, what are we doing, and what should we be doing in addition to what we're already doing. The patient's safety issues, what do we need to change in the care plans, and just having 5-minute stand-ups, quick little meetings rather than long meetings can be helpful to help change behaviors and change and update the plan of care for the patient. Offering risk and skin assessment information during shift reports is very important. This is one of the key areas we found in the New Jersey Collaborative, is that when you need the information to come alive, that it wasn't just buried in the patient's medical record, but actually was important and useful information, that people were more apt to do the skin assessments, they were more apt to do the pressure ulcer risk assessments and to do the interventions because they knew it was valued. When what you do is valued, people tend to do it. If people feel it's not valued, sometimes they can be reluctant to do the procedures and interventions that are required. Don't forget also to tell the patient and family what a pressure ulcer risk is. It's also very important to make patient and family understand why you're constantly looking at their sacral area, why you're looking at the heels, that these are areas where the skin can break down. Interestingly enough, in the study that I did that was published in Advances in Skin and Wound Care, people did report at the same level of percentage, 36%, that their facilities pressure ulcer incidence rate. Remember, it's important that they know what's available on their particular unit. Pressure ulcers are localized areas of skin injury. So localized knowledge of the staff is really important. Importance of nursing assistants and making sure that they have adequate knowledge. And there actually is a sheet that you can use, that resource section of the AHR toolkit. You can give to nursing assistants that if they see a problem with a skin while they're bathing or patient from the bed to the chair and it just doesn't look right, or there's something unusual with the patient, even if they may not know what the problem is or that it's a pressure ulcer or some other skin problem, they can mark the form and give it to the nurse so that this can get in there later on and do a full assessment of the patient. So rethinking how we use our nursing attendants can be very, very helpful. And there actually has been a study done by Susan Horn and her colleagues, and that resource is at the end slide, so do take a chance to take a look at them. How they educated the CNAs, this was in actually long-term care, but it certainly could be applicable in acute care, make them a very important and valuable member of the multidisciplinary team to help in the early identification of pressure ulcers, because frontline workers who skin and care for it every day might be the ones that might see a problem. And by using a tool that they could identify and giving it to the nurse, the overall percentage rate, there was a 42% decline in pressure ulcers in the 21 facilities that were involved in this implementation initiative. So they went from 4% to 2.3%. So it can certainly, the evidence shows that honing the resource of your nursing assistants in a different way can really make a difference. I mentioned, I'm just going to go back for 1 second. You mentioned about the guidelines that are available, the new PUAP, EPUAP, PPPIA guidelines. There are skin booklets out there. I did mention the New Jersey Hospital Association. You can go to their website. And having education materials readily available for staff, whether it's a pocket guide or a pocket guide book that they have. In some institutions have little cards that can attach to the staff's badge that they have with them. Some institutions create them. Some use education materials that are created by companies that make wound care products. But readily available, I think, is the key, so that staff can get information when they need it. Education needs to be done on a regular basis. It needs to be thorough in terms of, are we doing the interventions that we need to be doing for our patients? Are we communicating them? And have we streamlined some of the processes so that it makes it a little easier for the patient, for the staff to care for the patient? Some examples on the next slide. One of the ways you can do this is by making some practices universal. For instance, in your most critical ill patients in your intensive care units, many hospitals have gone to having all patients on pressure redistributing beds. So this eliminates the problem of deciding who's to be on them, the processes for ordering these beds, which in some institutions can be quite time-consuming, then getting the bed there and set up. So useful practices might be a way to go. Incorporating change into the routine care, for example, helping staff understand that when you're doing a skin assessment, you'd be doing double duty. For instance, when you're assessing breath sounds, you could be looking at the patient's back and sacral area. When you're looking at the abdomen, you could be looking to see if there are any continence or any skin issues that are going on with the patient. So the more that they don't see it as a separate action for pressure ulcer prevention, the more likely staff will be to do it. I mentioned the importance of integrating the pressure ulcer risk data so staff know it, and also that it needs to be part of the shift handoff or the patient handoff. It's easy to get equipment. This is one of the lessons we learned from the New Jersey Pressure Ulcer Initiative, is that if you lock up the equipment and the lotions and creams and the skin sealants that people need to use, it's an extra step. People are not going to use it, and then the skin won't be protected. Have electronic health records, make it automatic triggers that will suggest different care options. So, for example, if you have risk assessment tools such as a Braden scale, subscore moisture comes up as 1 being low, let us send a message to the caregiver, consider using protect the skin. You have different options, lotions, creams, and let them remember to use them, or that if the patient's immobile, you need to get a support surface on bed if they're not already on it. So other things that you can do is you can have automatic triggers or ideas to be getting dietary consults, high-risk patients if they have nutritional deficits, for example, or a consult for PT if somebody is immobile and needs to be moving or more, or OT. Having the supplies handy. Some hospitals have made skin carts. They put photos of the products on the drawers of the skin carts or in the supply room if that's where the products are, putting photos of what this is for, even streamlining the number of products that they have. Too many choices is not good for staff to have. Remember, dressings and products need to be available 24/7. That's hospitals are open 365 days a year, 24/7. So they need to have access to dressings and products. That pressure redistributing support is available for all critically ill patients. I already mentioned that. And prompts. Now, prompts can be visual or auditory, but I have to tell you that can be overdone. So this fine balance between reminding staff or would become immune to joggers that, I need to go in there and to the patient. So whether you use sound or whether you use charts, see what will work best for your staff, and you may need to vary it. Think about where the data is in your patient record. Is it scattered throughout the record, or is there one form that people find the information? So you might need to redesign your documentation system. Ask your staff, what do they think? They're the ones that have to record the information, so help them to look at that. The data in the patient's record can help you assess risk factors. I said, for instance, you can take a look at the medication profile. You can take a look at comorbidities, and patient history from the H&P that would alert that there were skin problems. And how can I put it in a logical flow so that people will be more apt to collect it and organize it? So having one form for all this information is usually best in most hospitals. For staff on these new practices, how do you manage process change? It takes a lot of time. It takes getting and addressing attitudes. It's best if you're going to be new new implementation steps for pressure ulcer reduction, that you do it one unit at a time. Ask for a unit to volunteer, for example. Make sure they have the data. You cannot manage change without data. Get the staff excited and engaged. Most nurses like a theme. If you can reward them in some tangible way, whether it's sending them food, giving them something that they value, a gift certificate to a spa day or something that staff might enjoy, can be helpful. And remember that whenever you start out on an initiative, the pressure ulcer incident rate will usually rise because people are more aware of the pressure ulcers. So staff will need your cheerleading so that they don't think, here I am doing all these good things and the rates are going up rather than going down. Help them understand that that's part of the QI process. And demonstrate them and help what they're doing, but do it in a non-blaming way so that people don't feel that if I make a mistake, it's going to have bad consequences for me on my whole staff evaluation. Help them to bridge the gap between the new knowledge and what they need to do. So by making them feel that they're a safe learning environment, they will feel the importance of buying into the pressure ulcer prevention initiatives because you have supported them. Take guidelines and tailor them to your hospital. For example, the new guideline says to do a pressure ulcer risk assessment within 8 hours of hospital admission. So, in your institution, to understand that resources that they need to make that happen, and that there's adequate time for their training and that they have the supplies available. Now, the implementation team, they're also important in managing the change process. Remember that they're looking at the big picture. They're helping to guide and coordinate it, all the change processes from a systems point of view. They help support the unit during the rollout in all phases of your pilot as you try to reduce pressure ulcers. They're going to work with the staff. They're going to work with the middle managers. They're going to work with the bed care providers. And they'll get information back up to senior leaders and administrators. Again, they need to have a strong link to the interdisciplinary team and to hospital leadership. They're going to be working with the unit champions and the unit leaders. They're going to continuously gather feedback, again, in a non-blaming environment, track the changes in the pressure ulcer rates and interventions, and make sure that everybody understands what those rates are. You start, make sure that that team is comfortable, that you've met with all of the implementation team and the unit champions, that everybody knows what their role and duties are. You cannot rely on memory here. So what are our prevention policies here? What are the interventions we have to choose for and accommodate based on the individual characteristics of the patient that we have on our hospital unit? How just roles and paths of communication? You know, how do I decide this? When do I know to call in a consult for somebody who's just not moving, or you know, the patient is not the patient does not want to participate in the plan of care. Is there somebody else who can come in here and talk to the patient and their family about the importance? Because maybe just not hearing me, they need to hear it from somebody else from the skin and wound care team. And you need to talk about how you're going to address and some of the barriers to adhering to this plan. Rollout, remember, you constantly need to remind the staff about why this is important. Remember that hospitals no longer get reimbursement for pressure ulcers that occur during the hospital stay. Staff may not remember that. Remember, the reimbursement is important because that's how the hospital has the money to do paychecks. So this is why we want to prevent pressure ulcers from an economic point of view, just in terms of that the hospital will get the reimbursement that it needs to have its own financial health as well as for the patient, because pressure ulcers are painful and can really delay the patient's discharge from the hospital. So involving the staff, getting them enthusiastic about pressure ulcers. Remember, a lot of staff didn't really learn about pressure ulcers in their initial education, so getting their enthusiasm up really requires some creativity, but most people like an initiative that has a theme, and getting them informed about progress is really important. So if some staff members resist change, that's good. Anticipate that it will happen. Find out why they are resistant. Ask them. Find out what's going on. This is the third initiative. So today it's pressure ulcers. Last week it was falls. Next week, what is it going to be? And there's just too much change going on. So find out what's going on the institution, or people just rotating too often to nights because staffing levels are down. Ask staff what's happening. They'll tell you. They're thinking about it, so they might as well be talking to you so that you can come up with a plan of care to have. Certain areas of the hospital, staff may not have been involved in pressure ulcer prevention, and one of those areas that comes to mind, and I'm not picking on the emergency department, since a large percentage of patients who are admitted to the hospital come through the ED, that's a logical place to involve them in a pressure ulcer reduction initiative. But quite honestly, in the past, they have not. If you look at a article by McNarrow and colleagues, which was done I believe it was done in Australia, in the ED, what they did is they really looked at trying to engage the staff in a shift, if you will, in a mindset shift about how important the emergency room is as a starting point for pressure ulcer prevention. When you do pressure redistributing mattresses, have you ever looked at the stresses that people lay on in the emergency room? You're your most critically hemodynamically unstable patients, yet you have a support mattress. It's outdated. When's the last time it was replaced? How narrow is it? For people of a usual BMI, but what about our bariatric patients with higher BMIs and they're laying on these stretchers for a long period of time? The patient has a cervical collar. Is it padded? There are studies out there that have indicated that the type of cervical collar can make a difference and increase the number of pressure ulcers from medical devices. Take a look at that. You may need to change your practices. You may need to change your equipment. It might be the equipment. So to look at that. And you may need to delay launch of an initiative if too much is going on in your institution. Education is really critical, and you need to identify any knowledge gaps. And in the toolkit, the AHR2 toolkit, you have a copy of the Piper tool, which has now been updated to the Piper Zukowski tool. And I have to tell you that pressure ulcers is a disciplinary initiative. It is not just about the nurses. In a study by Levine, for example, that physicians have pressure ulcer knowledge using the Piper tool about 60%, whereas in repeated studies that I've done with Karen Zukowski measuring nurses' knowledge, it's been in the C level in the 70s. So again, assessing staff knowledge and helping them to fill in those knowledge gaps are really important. Whereas we find is that people think that just because the patient's on a redistributing mattress, they don't need to be turned and repositioned, and that is not true. And where you are, where do you want to go, and creating that educational plan to address those gaps in your institution is the way you go. And that's where your education staff, it will be very helpful. I heard that adults learn best through methods that build on their previous learning experiences. That's how we learn as adults. So, real techniques to prevent what I call education fatigue, so that, how many webinars do people really want to listen to? How many online programs? How many lectures do people really want? If you use posters, vary them, vary the location of them, because otherwise people become blind to them. Some people have found that putting a very short poster in the staff bathroom is a way people like to read in the bathroom. So that might be one intervention for education that will help them. Having newsletters. Some institutions, this is a very powerful tool. One institution I know, when suddenly there was no newsletter in a month, people were actually for it because they really came to value it. It needs to be active. It needs to be didactic. So perhaps having somebody shadow or follow the wound ostomy incontinence expert in your institution is a way to really make it a lot, or embedding that person for a day to be on a unit and working with various staff to see how practices are. Really one way of making it come alive. So I hope that I've given you some ideas. I do want to mention the importance of organizing that plan at the unit level. For example, I did talk about the emergency room. I also do want to mention the room, which is another area that I've done some initiatives to decrease pressure ulcer incidents. So you could take a look at my work, which has been published with Barbara Delmore in the Journal of Ostomy Incontinence Journal, where we decreased pressure ulcers in our surgical patients by implementing a wristband for those patients that identify those at high risk after surgery, for example. Other universal practices that you might want to consider are shear reduction, and one of the ways that has been mentioned in the new guidelines, and there's growing evidence, is by using foam dressings. There's been a variety of studies out there that reported success in reducing pressure ulcers by using foam dressings prophylactically. Again, I think one of them is on the research list at the next couple of slides, and that would be one by Cubic, where they actually put silicone sacral dressings on the critically ill patients in the emergency room to reduce pressure on these patients, and found that the patients that didn't have sacral dressings were 5.4 times more likely to develop a pressure ulcer injury than those who did. So again, that could be part of your universal practices. Decreasing the amount of time that people have between identifying risk and actually providing the interventions is another way of helping staff. And again, that has to do with getting the equipment to staff in a timely way. Remember that training is paramount. In the survey that I Sharon Baranowski, a third of the nurses indicated that they had received sufficient education on care in their nursing education, basic education program. So, make sure that people have information, and just because they've been in practice for a while doesn't mean that they don't need an update, because there's new evidence coming out all the time on pressure ulcer prevention, and we need to make sure that people are up to date with the new guidelines. Thank you for being such great listeners. I'm sure that you will have questions, and again, please refer those to your QI specialist. Here's some of the resources that I mentioned. I talked about the survey. By Berlowitz and Van der and Parker was part of the grant from this AHR toolkit, and we actually have evidence tables from initiatives around the country, from hospitals and long-term care facilities, and what worked and what did not work in them. Certainly, there are resources in the toolkit back about assigning responsibilities for best practice bundles, the staff roles, and education. I just mentioned the cubic talk about reducing pressure ulcers in the ED, and there are others that look at intensive care areas in hospitals. I couldn't list them all. There's the Horn study that I talked about, CAs, and then the Levine study in terms of physicians. And I think that's a big barrier, that people feel that pressure ulcers are only the nurse. It is an interdisciplinary effort. No hospital has been successful that hasn't made this interdisciplinary. So getting doctors, other healthcare just on board is really important. I mentioned the Nakasero study that was done in terms of emergency departments. Rita Hauser article that was published in Advances in Skin and Wound Care, and that is open access. And the Sharkey articles with us and Horn about how to, once again, use nursing attendants to do early detection of skin problems, and then some of the work I've done on education. And with that, I want to wish you lots of success in your initiative. Well, keep the skin intact. Thank you.